as we know, when we are treating cartilage, we are looking for high regenerate quality because it is connected to the clinical outcome. And this slide is so important because when you are generating cartilage that is a higher line or higher line-like, the possibility of a good clinical outcome is really, really high. If you're generating something with low quality, so what is coming out of microfracture, the probability for a good clinical outcome is very low. And furthermore, the revision rate is very high. So in cartilage surgery, it is so important to have a high biologic potential, which is closely connected to regenerate quality and again, clinical outcome and long-term durability. And this is mostly true for the problematic lesions, osteochondral lesions, OD lesions, anything large, purely chondral above 3 to 4 square centimeter, and typically unstable knee joints, malaligned knee joints, anything patellofemoral behind the patella, so kneecap. And to my consideration and to our consideration, and this idea is getting stronger in my hands every day. The in vitro data are there, the basic in vivo data are clearly there, and this is not new information. The information is almost 40 years old now because Albrecht in 1983 already reported on that. I think the biologic potential of cartilage chips, particulated cartilage or minced cartilage, is very, very strong, which is related to an activation which is happening when you cut cartilage by sharp instruments. You are activating your cartilage, so the proliferation is going up to fill out the lesion. Extracellular matrix production is going up to fill out the lesion as well. And this process is happening at many different places. Approximately 150 chips can be transplanted per square centimeter defect size at a defect depth of approximately 2.5 millimeters. And David Frisby in 2009 already has shown in a translational horse model that cartilage chips, in that case, the KAIS product, had equal outcome from a histological side when directly comparing to autologous chondrocyte implantation. It was even slightly better, but that was only 6 horses, so no significant difference. But what was also very interesting in that study, when you're implanting a scaffold only, so an empty scaffold, the results are very, very weak. You are generating more scar tissue than higher line-like tissue. Where do we take the tissue from? We did the multi-center study and compared center of the defect to the surrounding of the defect, and clearly found out that most parameters are equal, but the typical chondrogenic potential was then significantly better in the periphery of the defect. And this is our preference of taking the biopsy for the AutoCart procedure. So if we have a fresh, pure delaminated cartilage flap, for example, fresh patellar luxation, we take that cartilage. And if you have a degenerative lesion or don't have any flaps available, we go to the defect edge and take also good looking pieces from the defect itself. And we showed in our own study that the cartilage is vital. It stays vital also in vitro for a long time and shows very potent outgrowth of the chips to fill out the lesion. At the same time, and this is also beneficial, and I think this is one clear advantage over ACI, that you are transplanting not naked chondrocytes, but chondrocytes that are surrounded by pericellular matrix, which is called the chondron, and many very important things for activation and differentiation of the chondrocytes are going on in the pericellular matrix. And if you contain some of that matrix, it is very important for further transplantation. This is how we started 7 years ago. Open procedure, taking out the cartilage, and then mincing by hand using a sharp instrument, which is very time consuming and is resulting in a block-like appearance of the chips. The problem with the blocks is, first of all, you don't have the chance to implant so many chips. That's one disadvantage. Further disadvantage is that the surface is not as large as in smaller chips, so the outgrowth behavior is not as well. It is not so easy to transplant. And finally, the ECM production, and this has been shown by a lab in France, actually from the lab from Bonasia, has shown that the ECM production is much better when you have a paste-like appearance when directly comparing to a block-like appearance. So this is the way it is currently recommended how it should be done. After defect debridement, you come in with a soft tissue shaver. This is a 3.0 saber device, and I take rounds at the defect edge. The good thing about it is that we have stable walls right away. We have vital cartilage, which is location specific. So when you are transplanting a defect at the medial condyle, you take cartilage from the medial condyle and transplant it at the medial condyle. And the same is true for all other locations. Then you collect it in the graft net where you can easily monitor how much you have. Usually you don't need so much as you collect, and then you are ready to implant that. When I debride my lesion using a sharp spoon, rinse correct, good-looking pieces, I don't discard. I also collect such by using also a soft tissue shaver device. My current favorite, because this is the smallest soft tissue shaver above 3.0, it's the 3.8 shaver, because it doesn't get stuck so easy as the 3.0. And it is still mincing in a very small fashion, very good for transplantation. So I used 2 shavers to collect my cartilage, the 3.8 for the bigger pieces and the 3.0 for the defect edge. And what you saw already in the video here, that on purpose I also shave a little bit into the Hoffa fat bed, because I want on purpose want to transplant some Hoffa fat tissue, because some stem cells reside in there, and that's a good combination for my cartilage. If I have a open procedure, I put my pieces into a basin underwater, cut it by hand using a scalpel again as in older days, and then I come in with my 3.8 or sometimes 4.0 shaver device and collect that. You can actually do the same thing under open circumstances. When you have identified your lesion, you are a little more aggressive on the Hoffa to have space, because later you will dry out the knee joint. Then you go in with an electrocautery to stop the bleeding in a preventive manner, because when you stop the water, it sometimes starts to bleed again in different locations. So I'm also a little more aggressive with my electrocautery device. Then always perform 2 portals, one for transplantation of the chips and the other one for control of the water. And if you have everything done nicely, you come in with a shaver, not strong suction, mild suction to dry out the knee joint. If you suck very strong, you provoke bleeding. And if you have done everything nicely, usually you just put out the water, put one larger swab underneath the condyle or at the lowest part of the trochlea to have control of the last water drops, and furthermore to have capsular distension, and then it is very easy to transplant your cartilage. Since collecting of ACP, you need 3 syringes. Sometimes takes a little while for the anesthetist to take the blood. This is the first thing, and you have to spin it down, and then it is sitting in the trominator 10-15 minutes. The whole process might take 25 minutes, and I have an isolated procedure. I'm done with my debridement very quick, and then I'm just waiting. So I tell my anesthetist to take the ACP very quick, and it can sit in the trominator after application of the 3 ml for 2 or 3 hours without a problem. The only problem you have that if you let the ACP sit, it will clot after sometimes after 30, sometimes only after 90 minutes is different. So I tell my nurse to shake it a little bit so it doesn't clot. The good thing about the ACP plus the chips is giving you an optimal paste, which is easy for transplantation and for putting across the lesion. It will coagulate over time, and it is a perfect carrier for your cartilage chips, and because it is a hydrogel in that way, and it is making it feasible to be arthroscopic in most cases, and you don't need any artificial membranes anymore because the stability of that carrier is more than enough, and at the same time you have a purely autologous carrier, which at the same time is pushing proliferation differentiation of your cartilage, while at the same time reducing some inflammation, and furthermore, and this is new information, it is attracting stem cells to the defect, and stem cells, as I said before, are working very good in synergy with the chondrocytes. So the current trend also in cartilage surgery is to do cells only, because the chondrogenic potential of artificial membranes and the mechanical stability, to my consideration, is overrated. Just one example, young lady, pretty large, a purely chondral lesion at the back of her kneecap. This was almost 3x2, so approximately 5 to 6 square centimeters, cartilage chips only, fixation only by autologous fibrin, and this is her 4 to 5 months MRI post-operative with a very good cartilage result. You see some remaining inflammation, some remaining effusion, which is normal at that time. Maturation processes are going on. The muscle is weak, and you see some typical bone marrow edema, which is going to reduce over the next couple of months. So this is a very good and very typical and absolutely normal early result. The good thing about, as I said before, the mixture of chips plus ACP gives you a perfect paste, and then after drying out the knee joint, it is very easy to transplant. You see here, I'm coming on the left image, coming in at the higher portal. In the lower portal, my swab is sitting for capsular distension, and then it is easy to apply the chips as much as you need. You can also apply 1 or 2 or 3 times. It is suggested to do that as well in a one step, and then you apply enough, and then you come in with a probing hook, or take the back side of that cannula to divide the chips across the lesion. In trochlear lesions tend to bleed a little more. It is suggested not to perform the procedure in full extension, but go in flexion as far as possible. You see here I have approximately 35 degrees of flexion, and then it is easy to transplant. And then according to defect size, 2 portions of nice chips bathing in ACP, and then it is very easy to divide them across the lesion. After application of the chips, out of the trombinator is coming thrombin, which are you dripping over the chips, and that is connecting built-in fibrin, and the last step is the fibrin glue. And if you do all that correctly, you can see here the fibrin is clotting while you apply it. It is very strong. It has a very high clotting potential, and you can actually finish the procedure a very few minutes after application of the fibrin glue. And this is how it looks like. Chips are in place. Thrombin is coming on top. You see here already coagulating, and in the right movie you can see the final layer of fibrin, which is making some bubbles, which is a typical very good sign, and it's pulling strings while it is clotting right away. And finally, you have a pudding-like appearance. This is cartilage surgery. It will be not absolutely stable, but this is normal and fair enough for 4 to 6 weeks partial weight bearing. And if I have some ACP left, I put that into the joint to reduce inflammation overall, to reduce pain overall, and furthermore, and this has been already shown in nice trials in knee arthroplasty, it is reducing bleeding of the joint, so the rehabilitation is being much faster. My last step of the AutoCart procedure currently is that I perform full extension flexion maneuvers no matter where I have transplanted my cartilage, to have two things. First, I want to have safety that my chips are not dislocating. At the same time, by the flexion extension maneuvers, I have a mechanical effect that the chips are a little better pressed into the lesion, so they are molded into the defect, and you have a perfectly gliding surface. And you can see here the fibrin is very stable and no single chip is moving or dislocating in any manner. The same is true for the problematic lesions, where you have much more friction at the patellofemoral joint. This is a trochlear lesion you just saw before. You see here the bubbles of the fibrin. Lesion is nicely filled up. I don't fill it up to the full height anymore, only 70 to 80%. Here's my swab sitting there, and you can see no chance for the kneecap to dislocate the chips at the kneecap. The good thing about the arthroscopic approach, this can sometimes be challenging. You can also address I would say seldom locations, such in this case lateral tibia plateau in this young lady who had a valgus deformity. But here this was going far under the meniscus, so I had 4 portals here, just one portal for my swab to pull up the lateral meniscus and to stop the bleeding, and the other lateral portal for application of my chips, and 2 medial portals for visualization, and one more where I put my shaver into the notch because it was bleeding so hard. But if you do that correctly, then you have also the chance to have a high biologic potential at the tibia plateau. And here I performed the varization osteotomy at the same time, so single step procedure, minimally invasive at the joint, and so far the lady is doing very, very well. Now I have gone a little further. This is a young lady. She's approximately 40, came into my clinic with a pretty large medial femoral condyle defect. Much more closely looking at the MRI, but I actually overlooked that in the clinics. She had also some degeneration at her trochlea, while the remainder of the joint was nice. This was her defect at the medial condyle in a typical manner, very easy to treat. But she had also 2 defects at the trochlea, this double eye lesion with the crista intact. So in this young lady, because I had many chips left, I decided to transplant that as well. And if you do it nicely and you are able to dry out the knee joint in a good manner, it is easy to also treat multiple locations, where I have many patients currently which are young, have multiple locations, and we should give them a chance. It is very clear that the clinical outcome will not be as good as in multi-locations, but here it is a young lady. I had enough chips. It was easy to dry out the knee joint, so I gave it a chance. I just saw her 2 weeks ago in my outpatient clinic, 4 months after the procedure. No crutches, no pain, no swelling, weak muscles, but so far she is doing nicely. You can combine the AutoCart procedure with actually anything you want. I frequently combine it with ACL surgery because in fresh ACLs you see a lot of lateral cartilage damage in chronic lesions, typical medial condyle, plus MPFL, which is very often in chronic patellofemoral instability, where you perform MPFL plasty, which is very frequent is osteotomies, cancellous bone plasty, arthroscopic or open procedure, meniscus suturing, and anything typically at the patellofemoral joint. One case, young ice hockey player, dislocation of the kneecap, large purely chondral flap, which was dislocated, typically residing in the lateral recesses. I took that out. Why should I discard it? I minced it back, so I cut it by hand into smaller pieces, performed an arthroscopic AutoCart procedure at the kneecap, plus a minimally invasive MPFL. So she had a minimally invasive approach, purely autologous, one-step procedure, and so far she's doing very well. And as you know, who is treating a lot of patellofemoral cartilage lesions, all that patellofemoral cartilage lesions which are malaligned and unstable, and they almost all have cartilage lesions at the kneecap, and here it is, or at the trochlea, or both, and here it is easily perfect. If you have the joint open, anyhow, you just can quickly put in the chips, and this is in my hands a very frequent procedure in tuberosity osteotomy, but also in trochleoplasty, because almost all patients in trochleoplasty have cartilage damage, and it's so easy to combine that here. I do it just accordingly to the arthroscopic approach. I mince it out of the joint, put the chips in. Here you see the chips are a little bigger because I used a 4.0 shaver device. It still works, but it is not truly suggested. Thrombin and fibrin on top. And I don't put the chips up to the full height. As said before, only 70–80% to have some remaining gap to prevent delamination, and then a bigger layer of fibrin glue on top, which has an orange or yellowish appearance, and when it is clotting, it gives you a very good sealant, and the cartilage can get active right away. So it is easy to combine it. Again, kneecap defect. In this case, osteochondral, I perform a cancellous bone plasty. You can do that autologous or allogenic. In smaller lesions, I tend to do it allogenic because it is quicker, but in OD lesions might be reasonable to replace it with something else. If I perform an allogenic procedure, I bathe the chips in ACP, and then I perform a cancellous bone plasty. Wait a little bit until it is very stable and some clotting has happened, and then I put my chips on top with the AutoCart procedure in standard fashion. And you can see here again, I don't fill it up to the full height. One more example for that, a little older patient who was 45 at that time. He had an osteochondral lesion at his lateral trochlea, maybe an old OD lesion, which would be typical. Here I performed an arthroscopic cancellous bone plasty using, again, allogenic bones. So I clean it out, and then I put my bone on top, and I press it down. Sorry, and then I put my chips on top, purely arthroscopic, which is working nicely. One further step I have done now, if I have very large lesions, revision cases, such in this young lady who had a large, previously multiple times operated OD lesions at the medial condyle while it was still being only 19. I performed a large cancellous bone plasty plus chips on top, and because in this case I was actually a little concerned about mechanical stability, and I didn't want that young lady to have a revision again, so I took out a synovial flap from the suprapatellar pouch. Then you can trim it down because it has multiple layers to one very thin layer. It is very strong, has a good flexibility, and you can partially see through it, and then it is very easy after cutting it to the defect dimensions to put it on top of the lesion, some interrupted 6/0 sutures and fibrin on top, and it gives you a very stable construct. And at the same time, you see again synergism between the chondrocytes and the synovial membrane, which has been already published. The same is true for bipolar, absolutely salvage lesions. This is a young patient who would have required Pat-Fem arthroplasty, but he didn't want that, so I talked to him, and we decided to perform an AutoCart procedure in a bipolar fashion, so a little lesion on the central to lateral trochlea and a very big lesion at the kneecap. And on the bigger lesion, I put a synovial membrane on top for stability reasons, because it was so large, and for reasons of the chips on the opposing trochlea so they don't cut themselves off. So far, also this patient is doing pretty fine, but we have to wait for longer term results. The ACI rehabilitation is the same as to ACI, but in my hands I see a difference that the subjects are doing better early on, so less effusion, less pain, less crutches, more movement at 6-8 weeks after the procedure. This is related to the arthroscopic approach, as you can see here in most cases. At the same time, I think it is related also to a purely autologous approach, no artificial membranes, and it is related to the biologic potential of the chips, and it is related to the effects of the PRP of the ACP. This is a neurologist who had a degenerative lesion at this medial trochlea, came into my clinic, purely arthroscopic approach, which is clear. This is the CHIPS procedure, one of my earlier ones, and not the perfect application so far, but fair enough. This is a 6 months MRI. You see defect doesn't look very good, but this is not the whole truth. Still some effusion, but not much pain. So what can you do here? Revision is not suggested when the pain is okay. Just wait, give some more rehabilitation. And you can see here, there's a strong trend for more maturation between 6 and 12 months, and many defects are evening out by the AutoCart procedure. And now finally very good results, no more effusion, no pain, return to sports. This is a rheumatologist. Actually, he came to my clinic with a partially traumatic, partially degenerative lesion. He's 47. At his medial condyle, the remainder of the joint is absolutely perfect. This is his defect, approximately 3.5 square centimeters, typical CHIPS procedure, as you have seen before in my movie. And since he's a rheumatologist, he was very concerned. He performed an MRI already 3 months after the procedure. He has no pain. He's very satisfied. And this is a typical MRI. You see some heterogeneity within the transplant, but good integration at the posterior border, some more to do at the anterior border, but there's clearly cartilage when you play with the contrast. Height is already very good. Subchondral bone looks good, but you see a very strong localized bone marrow edema that is partially looking like a fire. This is absolutely typical and normal with the AutoCart approach at 3 months post-operative. It might remain like that, but reduced at 6 months. And between 6 and 12 months, this bone marrow edema is usually going away and the final maturation is happening. In some patients, the cartilage looks already perfect at 6 months. Some patients take 12 months, but this is a very typical and absolutely normal 3 months MRI. And this is a current publication that came out end of May, but I just saw it a couple of days ago, coming from Asia. They performed both-sided AutoCart procedure at the medial condyle and the varus malaligned subject. They performed HTO. HTO was not perfect because the MPTA now seems to be 100, but still it is unloaded. And they performed, after the removal of the plate, performed a T2 mapping procedure, and they showed a very good cartilage signal already also 3 years after the procedure. So you don't see a typical drop as in microfracturing, so the biologic potential is there and a very good cartilage signal. But in general, the clinical evidence is very, very weak. We published 27 patients, but that was still with the membrane, good results. We are currently working on the 5-year data. And Ramon Cugat from Madrid reported his approximately first 15 patients using PRP plus chips in a mini open approach, also so far very good results. So AutoCart is not an expensive procedure. It is beneficial because it is purely autologous, homologous, and it is optimally, when you treat by location, topology correct cartilage. So if you're treating patella, take cartilage from the patella, trochlea, and so on. It is a one-step, one surgeon, 1 hour procedure. In most cases, it is arthroscopically feasible. So I open up patella and revision cases in selected cases, but I try to push to do everything arthroscopically. You don't have any substantial change of tissue for that. It is no ATMP. I currently use it for any chondral and osteochondral lesions. I start at 1 or even smaller square centimeters, and the largest one is 10 square centimeters. The biologic potential is clearly there to cover up also very large lesions. You have location-specific PRP-boosted, fully differentiated cartilage. So the cartilage is not de-differentiated coming out of the lab as an ACI, and you don't see any senescence. And for that, I see a clear advantage over concurring procedures. And just 2 more examples: young patient, traumatic trochlea lesion, dashboard injury, and this is his intraoperative C2, and this is his 6 months MRI. And you see here, he's young, very strong, very fast. Reconstitution of the defect, still heterogeneity, bone marrow edema is significantly reduced, and the subchondral bone plate is intact, no pain. And the same is true for osteochondral lesions. Thank you very much.